Okay, folks, we are moving into our third unit, which is going to look at the bioethical principle of beneficence and non-maleficence. All right, so fancy words, but just basically dealing with this idea of aiming and providing a duty to do good and to minimize discomfort or evil. Okay, sounds pretty simple, and yet the first few pages of the chapter recognizes that there's really an impossibility of doing all good. There's going to be a limit of time and space in which we can treat patients. We have limitations of talents and skill levels. Even with our abilities, we are limited by technology and resources. We can't always do everything that we feel is necessary for a particular patient. And as we look at the other side of that, trying to avoid discomfort, or to use the term evil, um, is also impossible. It's interesting to note, and we'll talk a little bit more about that dimension of the Hippocratic Oath. But one of the things that Hippocrates stated early on in Greek civilization is to avoid surgery. They simply recognized that cutting a person open didn't end well. So there are going to be ways in which, whether it's a surgical procedure or even giving medicine, implies certain levels of side effects or discomforts that are unavoidable. So how do we make sense of this? We're going to take a look at back to our utilitarian theory or consequential theory, just to try to get a sense of the history of some of these ideas of how we balance both positive and unintended negative effects. But here's a focus question, and for those who are interested particularly in end-of-life issues, this is a real application of beneficence. Once a patient has requested a physician to control their pain as a priority, can that physician increase a dose of morphine as needed to control pain, even if that might cause the patient to stop breathing? So again, trying to take the bioethical principle and looking at some applied cases. So let's go back to some of the thinkers that we did in the first unit, and we're going to take a deeper dive into utilitarian theory. And here we are with Jeremy Bentham again, saying that an action is moral if it produces the greatest good for the greatest number. And as we kind of talked about in that first discussion thread, well, how do we measure what a good is? So we just want to try to take a look at how both Bentham and Mill tried to do that. Bentham came up with this idea that there were hedons, actually units of pleasure, that could be measured. And he referred to his ethical analysis as a hedonistic calculus. He used some of the following measurements to define these hedons: the certainty of the pleasure, the intensity, the duration, fecundity, meaning how likely would this action or decision lead to a further experience of pleasure, how long between the action and the resulting pleasure. Bentham really got criticized in some ways of this hedonistic calculus because he, was kind of seen as, they called it a swine morality. It was just kind of based in bodily pleasure, and that was it. But I think if we were to use these measurements, we start to see that what Bentham was interested in is overall health. A quick example of chain smoking, while there might be an immediate pleasure from the nicotine, if we were to imply, duration and some of these other factors, overall, it's going to lead to a real detriment in health. But as we move to John Stuart Mill, who also agreed that we want the greatest good for the greatest number, and that happiness can really be defined in terms of pleasure, he started to respond to these criticisms of swine morality, and that this was a morality just based on bodily pleasures, by saying that there were intellectual pleasures, also hedons, but that were simply of a higher quality and kind, that we can't just put a number and work it out systematically, but we also have to see that, for example, doing philosophy is just going to be a much higher hedon than eating or drinking or things like that. And while Bentham did not go in that direction, Mill tries to say that intellectual pleasures are simply better than bodily pleasure in kind. So how does this relate to some of our discussion of medical and healthcare ethics? We do want to say that there are certain goods that are part of human dignity, certainly nourishment, shelter, clothing, and in many ways we can see these as kind of bodily needs. But we can also see that there are social, psychological, intellectual goods that should be thought about as we're thinking about producing a good for a patient. Membership in social groups, how healthcare is understood in the wider society. We can't always know all the goods that a patient desires through law or custom. And it brings us back to our earlier unit on informed consent. But it is part of our obligation as healthcare providers to try to provide as much beneficence as possible and avoid displeasure. So again, one of the very early statements was actually not in the original Greek of Hippocrates, but as it was Latinized, do no harm, primum non nocere. So this idea of trying to avoid injuring our patients further. But how do we define that harm, and how do we measure those necessary pains that might be needed in order to produce a greatest good? Um, Before we dismiss Bentham and Mill's notion of these hedons, it is interesting that we still use some sort of a scale in a similar way when we ask patients to self-report levels of discomfort. Where is your pain on a level of 1 to 10? This is subjective. We understand that it's going to differ for people, but it is a way that we try to get a sense of this. I have a friend who works in OBGYN, and sometimes for younger moms, she'll say, where are your labor pains, and they'll kind of say a 6 as they're eating a sandwich or relaxing and talking. She's like, that's not a 6. You'll know when that comes. So we're going to talk a little bit about ways in which we try to evaluate this balance of pleasure and pain. Just one quick connection. We're going to make a few other connections to our nursing code of ethics. But as I looked at provision number 5, it was interesting to note that while so much of this is focused on building good and pleasure for the patient, nurses owe the same duties to yourself as to others. And so there was a discussion about compassion fatigue, and maybe nurses particularly are on the front line of this. Certainly your focus is on the patient, but there was a lot of interesting duties that are noted in provision 5 that are really about your own health and well-being and producing good for yourself. So definitely something to consider in terms of your own self-care as well. Okay, we're going to move into more of a discussion of these principles of proportionality, and then we'll look at some certain duties around decision making.